Hello everyone. Today's topic of discussion is about disseminated intravascular coagulation. The following topic is discussed under the subheadings such as the definition, etiology, normal hemostasis, pathophysiology, clinical manifestations, laboratory findings, differential diagnosis and treatment. Coming to the definition, it is also known as the defibrillation syndrome or consumption coagulopathy. DIC is also known as defibrillation syndrome or consumption coagulopathy. It is an acute, subacute or chronic thrombohemorrhagic disorder which is characterized by the excessive activation of coagulation and the formation of thrombi in the microvasculature of the body. It always occurs as a secondary complication of many different disorders. Coming to the epidemiology, it occurs in 30 to 50% of patients with sepsis. It develops in an estimated 1% of all hospitalized patients. It occurs in all ages and it has no sex predilection. Coming to the etiology, there are certain infectious causes resulting development of DIC. Tissue injury can occur, leading to, whenever there is tissue injury occurrence, it can lead to development of DIC due to multiple fractures with fat emboli, crush injury, head injury, such as factors. Malignancy can also lead to development of DIC due to presence of acute myeloid leukemia or acute plasmacytic leukemia, neuroblastoma, adenocarcinomas of lung, pancreas, colon, stomach can lead to development of DIC. Venomous toxins, snake bites, insect bites can result in development of DIC. Microangiopathic disorders, TTP, HUS, Kashabek-Merit syndrome are these microangiopathic disorders which can result in development of DIC. GI disorders which include fulminant hepatitis, inflammatory bowel disease, pancreatitis, which can result in development of DIC. Hereditary thrombotic disorders which include antithrombin 3 deficiency, homozygous protein C deficiency can result in development of DIC. In newborns, DIC can develop because of maternal toxemia, abruptio placenta, necrotizing enterocolitis, erythroblastosis fetalis. There are some miscellaneous causes which can result in development of DIC which include acute graft rejection, acute hemolytic transfusion reaction, collagen vascular disorders, heparin-induced thrombosis, hyperpyrexia. Come to the physiological aspect, the normal hemostasis which is explained here include 4 phases which include the vasoconstriction, primary phase, secondary phase, thrombosis and antithrombotic phase. So this is the pictorial representation representing the normal hemostasis which occurs, which include the vasoconstriction, primary, secondary phases, thrombotic and antithrombotic phases. So this is the pictorial representation representing the coagulation cascade, which include extrinsic intrinsic pathway. Both meet at the common pathway, which result in formation of the stable cross-linked fibrin clot. Coming to the pathogenesis, DIC is not a primary disease. It is a coagulopathy that occurs in the course of a variety of clinical conditions. It results from pathological activation of coagulation or the impairment of clot inhibiting mechanism. Remember, it results from pathological activation of coagulation or the impairment of clot inhibiting mechanism. Pathogens of DIC result from following 4 simultaneously occurring mechanisms such as tissue factor mediated thrombic generation, dysfunctional physiologic anticoagulant mechanisms which cannot adequately balance this thrombic generation, impaired fibrin removal due to depression of the fibrinolytic system, inflammatory activation. This is the most important slide of this topic, which is pathogens of DIC. Whenever there is a release of tissue factor, it results in coagulation cascade activation. On the other hand, whenever there is an endothelial injury, it results in platelet aggregation. Coagulation cascade activation, platelet aggregation, both results in widespread microvascular thrombosis. The widespread microvascular thrombosis on one hand results in vascular occlusion, which results in tissue ischemia and microangiopathic hemolytic anemia. The widespread microvascular thrombosis on the other hand results in consumption of clotting factors, which ultimately results in bleeding. This widespread microvascular thrombosis can also result in plasmin activation. This plasmin which is activated can result in proteolysis of the clotting factors, which results in bleeding. On the other hand, the plasmin which is activated can result in fibrinolysis, which results in fibrin split products production, which results in inhibition of thrombin platelet aggregation and fibrin polymerization. This inhibition of thrombin platelet aggregation and fibrin polymerization all result in formation of bleeding. There are certain conditions such as placenta abruption complications, tissue injury in bones or trauma, mucus from adenocarcinoma can result in development of DIC. There are certain sites of thrombosis. Upon decreasing order of frequency, brain, heart, lungs, kidneys, adrenal, spleen, liver are the sites of thrombosis occurring due to DIC. Signs and symptoms of DIC include renal failure, cough, confusion, decreased platelets, blood clots formation, drop in blood pressure, sudden bruising, bleeding possibly from multiple sites in the body, fever. These are certain signs and symptoms developing due to DIC. Complications of DIC, which include acute kidney injury, change in mental status, respiratory dysfunction, hepatic dysfunction, life-threatening thrombosis and hemorrhage, which are seen in patients with moderately severe to severe DIC, cardiac tamponade, hemothorax, intracerebral hematoma, gangrene and loss of digits, shock, death can occur sometimes due to DIC. Coming to the laboratory findings, complete blood count has to be performed where we find severe thrombocytopenia with or without anemia. Peripheral blood smear had to be performed where cystocytes are seen due to microangiopathic hemolysis. PT and APTT levels are prolonged. D-dimer, fibrinogen or fibrin degradation products are elevated or increased, which are more than 25 microgram fibrinogen equivalents per ml. Protein CES and antithrombin are decreased. Markers of endogenous thrombin generation, which include prothrombin fragment 1.2 and thrombin antithrombin complexes, the TATs are elevated. Certain differential diagnostic findings should be evaluated from the DIC, which include the TTP-HUS, atypical HUS, ITP, cirrhosis, HIT. Whereas in TTP-HUS, which include platelet count level is decreased, PT-APTT levels are normal, fibrinogen level is normal. In ITP, platelet count level is decreased, PT-APTT are normal, fibrinogen level is normal. In cirrhosis, platelet counts are decreased, PT-APTT are prolonged, fibrinogen levels are normal to decreased. In HIT, hyperemesis thrombocytopenia, where platelet count level is decreased, PT is normal to prolonged, APTT is prolonged, fibrinogen level is normal. Coming to the DIC, the platelet count is decreased, PT-APTT levels are prolonged, fibrinogen level is decreased. There is an acute DIC algorithm proposed by the International Society on Thrombosis and Hemostasis, which include whenever there is presence of an underlying disorder known to be associated with DIC, if yes, proceed, if no, do not use this algorithm. There are certain global coagulation results which include platelet count, fibrin degradation products such as D-dimer, prolonged prothrombin time, fibrinogen level. Whenever the platelet count level is less than more than 1 lakh, score is 0, less than 1 lakh, score is 1, less than 50,000 per microliter, score is 2. Fibrin degradation products such as D-dimer, whenever the D-dimer levels are show no increase, score is 0, moderately increase, score is 2, strongly increase, score is 3. Prolonged prothrombin time, whenever the PT level is less than 3 seconds, the score is 0, more than 3 seconds, score is 1, more than 6 seconds, score is 2. Fibrinogen levels more than 1 gram per liter, score is 0, less than 1 gram per liter, score is 1. Interpretation, a score of 5 or higher, it is interpreted as acute DIC. The algorithm can be repeated on occasion if acute DIC remains a consideration and the laboratory values change. Treatment, the most important factor in the management of DIC is the treatment of the underlying cause. Supportive therapy may be given to patients with excessive bleeding. So the supportive therapy can be given such as fluid administration, blood transfusion, transfusion plasma administration, platelet concentrate administration, fibrinogen can be administered. Patients with chronic DIC and thrombosis may need heparin therapy. Thank you very much.